Good morning, everyone. Welcome to the third annual IMD&U Day. Very pleased to have you here, and this is a different format for IMD Day, but like most things we do as the Illinois Medical District Commission, this format is informed by our partners, our partner institutions, and our partnering entities that work with us here in the Illinois Medical District. At the end of each previous IMD Day, we've asked for comment and feedback, and in fact the blue piece of paper on each one of your seats is one of those comment documents that we'll ask you to complete. But it was suggested to us that we enhance our informational fair and what I like to call our IMD block party, which will begin formally at 11:30 this morning with some informative workshops around relevant healthcare topics of the day. And so as a result of that feedback, we have incorporated that format, and this is the first of 3 sessions that will be held this morning around those topics. I'd like to just recognize initially the president of the Illinois Medical District Commission, Jennifer Woodard, and thank her for her ongoing support and leadership. We both have been here at the Medical District 30 months now, and believe that we've accomplished a lot in revitalizing the district, but also recognizing we still have a lot of work to do. But it's a true pleasure to work in partnership with Jennifer, and I think it's fair to say we both enjoy getting up and coming into the district for the challenges that we're trying to address. Also, I just want to recognize a company that is represented here today that doesn't now formally have a presence in the Illinois Medical District, but has really become a partner with us, and we believe that someday definitely will have a presence. They certainly recognize the value of the research opportunities and the patient populations of the medical district, which provides some very unique characteristics compared to other medical districts, and that is Quintiles. And Quintiles is represented by Patrick Jordan, who's actually not in the room at the moment, but also by Jennifer Karstens, who is with us with a company called Encore, which was a recent merger with Quintiles, and Jennifer actually has roots here in Illinois. So very pleased to have Encore and Quintiles with us here today. So the first panel is entitled Community Health and Technology. I'm sure probably every one of you in the room has at least one of these devices, if not both of them, right? Be surprised if any of you don't. It's pretty remarkable how these little handheld devices are impacting healthcare delivery. They certainly impact every phase of our life in bringing about ease of access of information of any kind. The panel that we have with us uses technology, much of which can be derived and seen from these types of handheld devices in different ways. And you're going to hear a lot of terms today, such as health information technology, electronic medical records, informatics, comparative effectiveness research, patient-centered outcomes. All of those terms are in their everyday vocabulary of the panelists that are with us here. But we as healthcare consumers are sort of mystified at times by those terms and what it really means. So the panel is going to help explain that to us, because truly the way that technology is being employed today, and particularly information technology, is changing the course of healthcare delivery, but much more importantly is really changing the research aspects through the collection of mass quantities of healthcare information at the individual patient level, then that is aggregated and then analyzed in a number of research capacities. So it really is that type of research which is patient-centered that is driving the day-to-day activities of each one of these professionals. It's also being driven by the new era of healthcare policy in the United States that was enacted through the Patient Protection and Affordable Care Act. That's the formal name of the act that Congress passed not too long ago. It's more often referred to as the ACA, the Affordable Care Act. But I think it's really important to focus on those first two words, patient protection, because I think it emphasizes that the new delivery of health care truly is patient-focused at the individual level, which is really community health, and also recognizes the need for the safe and secure use of the health information that's contained in these vast electronic healthcare records. So, I think it was pretty informative to really lead the this new healthcare policy with patient protection. You know, it's interesting. We all get a lot of emails every day, and I just happened to got one this morning at 7:25, and the leading sentence, I think, is a pretty good summary of sort of the things we're going to talk about. And let's read this first sentence. It says, "Good morning. The global healthcare industry is seeing new developments, improved point-of-care diagnostics, cost-effective treatment modalities, and advances in personalized medicine, which not only offer efficient early diagnosis, but also allows for the treatment of, in this case, cancer conditions in order to reduce the healthcare cost and disease burden." And that's really what the research efforts are designed to do. It has to address the healthcare costs, make improvements in discoveries and reducing the disease burden at the individual level. So with that, I want to introduce the panelists today. First, to your far right is Dr. William Trick with the Strozier Cook County Hospital. Bill holds a faculty position within their collaborative research unit. And he has a particular interest in electronic medical records and the incorporation of information technology innovations to support clinical research and public health applications. In the center is Dr. Denise Hines, who is a professor of public health with UIC's College of Medicine, and also a research scientist in the Division of Public Health Administration within the School of Public Health. Dr. Hines is also director of the Biomedical Informatics Core of the Center for Clinical and Translational Sciences. She has developed and utilized databases and informatics throughout her health science research career. On your far right my left. Got that? I think I got Bill's wrong, didn't I? Yeah. I always get mixed up here. So, which left is it? Is Jamie Parent. And Jamie is Vice President for Information Technology Operations and Associate Chief Information Officer with Rush University Medical Center. Jamie is responsible for the day-to-day technical operations for infrastructure, security, networks, databases, and all user endpoints. And he also oversees research IT and IT support for Rush University graduate schools and the School of Medicine. All three of these individuals are well recognized within the city of Chicago, the state of Illinois, and in fact, because of some of their collaborative work, are developing national reputations for the work that they are doing around informatics. So we're going to start off this morning by asking each of the panelists to give us a little bit more information about their background and really how they use their day-to-day experiences by using technology to address the issues of community health. Bill, please.
So, good morning. Thank you for having me. So, a little bit about my background. I was a practicing internist for about 4 years and then moved to the Centers for Disease Control, where I was an EIS, or Epidemic Intelligence Service Officer, for 2 years in the Division of Healthcare Quality Promotion, which at that time was sort of the stepchild of the CDC. It was a place where clinicians went to learn about public health, but some in public health felt it wasn't really a public health activity. Since I've been there, and I stayed on at CDC for about 4 years, and I've seen that division grow and actually become more incorporated in public health. And I think that's one of the messages of today, is that as the electronic health records evolve, there are more opportunities to look at health of the population or health of the community. So when I first started, what they do is they send you out to hospitals for outbreak investigations, and that means going to a medical record room, and you quickly realize how much information is trapped in a paper record sitting in a room somewhere. So that's been released with the advent or the actual much better uptake of electronic health records, but it still gets trapped within an institution. So how do you get that across institutions? And that's what a lot of the work that we're trying to do in the Chicago area and actually nationally is getting data to cut across institutions. And then beyond that, I think the future is not only are data trapped within institutions, but they're trapped within individuals. So can we, as healthcare facilities and healthcare organizations, unlock the important data that patients have about their health behaviors, about their outcomes, their quality of life, things that aren't routinely captured in the clinical encounter. But if we can capture that in a standardized way and share that across facilities, then we can start to get a better look or better sense of community health and community behaviors. So public health, it's a strain for them to capture that information at each, to the community level now. They might do community surveys or telephone random digit dialing surveys, but those are expensive and labor intensive. So there is, again, more of an intersection and understanding between the healthcare institutions and public health. And so the two sort of worlds that I live in, coming out of public health and now practicing medicine at Cook County Hospital, one of the activities is running a clinical data research warehouse. So we get data out of HIS, we extract the data, we transform the data, and we try and make that data available to researchers, also for quality improvement projects. Because of the relationships we've had with public health, we also wanted to get data to public health for activities. And when you think about community health, some of the applications are surveillance applications. So where are our problems with this certain disease category? Can we map it to the neighborhood level? Can we intervene at that neighborhood level? Can we follow those interventions and see if the population changes? So rather than making inferences about a population from national data and looking at the demographics, they'd really like to get those data on a more granular level. The other is not just the population level, but can we do interventions that cut across the healthcare institutions? So I'd call these community health, where someone might have been tested for a disease in one institution. They don't go back to the institution. Did they fall out of care? or did they get their care somewhere else? So for an individual institution, unless they're part of a managed care or part of the population they're trying to manage, that person disappears. From a public health perspective, they want to be able to track, did this person with hepatitis C get into treatment, or did they fall out of treatment? So in addition to sort of looking at population management, if we can share data, we could also look at treatment trajectories for an individual. And so one of the other projects is HIV treatment and looking, did people fall out of care? We have effective treatments. Can we get them back into treatment? So it's looking at building registries and case management tools that cut across institutions. So one of the ways to help realize this, I'm the director of the Collaborative Research Unit, as Warren mentioned, building the local data warehouse. But we realized to share data, we needed to build an institution outside of this. So we've built what's called the Public Health Node in close collaboration with the Illinois Department of Public Health, where we receive data and send those data to the Illinois Department of Public Health. To do that, we knew people wouldn't want to send their data to Cook County Hospital. They wouldn't want to send it to Northwestern, to UIC, to Loyola. They don't want their data going to other institutions. So we started a nonprofit that houses the IT infrastructure on co-located servers to collect the data. It's designated it as an agent of the Illinois Department of Public Health for these activities, and we can start to build interventions around that. And in case I don't get to it, one of the examples would be we're building an XDRO registry for extensively drug-resistant organisms, where we track patients who have these organisms and whether they're admitted to other hospitals, and our goal is to set up a communication network between facilities. And so one of the collaborations I'll highlight is someone from the UIC School of Public Health who's in the audience. Michael Ray has worked with us a lot on this, and he's been able to use cluster detection software from Harvard to look at clusters of XDROs, and we plan to automate that and feed that information back to public health to look at clusters. So maybe a little longer of an introduction, but I'll stop there, and again, appreciate the time here.
Yeah, thank you. And we, I'm going to ask some questions, but we also want to encourage questions from the audience, and I think we can be pretty informal. We'll just let you shout it out, or if you feel more comfortable, I think we have some forms you could write out the question. So with that, Denise, please.
Thank you, and good morning, everybody.
Good morning.
My name is Denise Hines. My background is actually nursing, health policy, and health economics. And in addition to my appointment here at the University of Illinois at Chicago and the good work we're doing there, I've actually been also a part of the U.S. Department of Veterans Affairs since 1991. I run a research resource center called the VA Information Resource Center based at the Hines VA Hospital out on the Loyola and Hines shared campus in Maywood. One of the aspects that I'm very excited about these days is I sort of feel like I'm kind of coming back to my roots with some nursing. The research that I've been involved with over the years, immediately coming into the VA and at that time Duke University, we were looking at issues around women veterans and their use of VA healthcare. And I recall coming into the VA and thinking, there's not many women in the VA, and clearly not all of their care is in the VA. And along with many other chronic diseases that we were examining, immediately the issue comes up of trying to understand the comprehensiveness of healthcare. Electronic medical records, large databases, claims databases are very useful for studying population health, but unless you can look at the entire continuum of healthcare, you always feel that you have some gaps. So one of the aspects early on that I became involved with in both the Department of Veterans Affairs and my university affiliates is working with electronic health records as well as claims data from both Medicare, Medicaid, and some of the other related programs. That provided some, if you will, gap filling to understand healthcare that might have been provided outside one institution and allow one to look at if a patient is coming for the mammography at one facility, but they might be using an emergency room at another, or looking at their preventive health care at yet another institution. So those aspects of working with large data became very important. Another aspect that has become really exciting in more recent years is the involvement of patients in helping to understand and to inform how research is done. And that's where we come to the patient-centeredness of healthcare. You would think that it's always been that way, but when we start looking at issues around research and scientific questions, sometimes involving the patients and the patient population can actually provide more insight into how you actually ask the questions, as well as how you answer them and the methods that you use. So for example, coming back to my roots, I'm involved right now with a study funded by the Patient-Centered Outcomes Research Institute, PCORI, that's looking at dialysis care and adding primary care, general medical care, preventive care to the care of those patients. Oftentimes, patients on dialysis can actually be on dialysis for a long time, waiting for kidney transplant, or on maintenance renal replacement therapy. And involving the patients in that process has enlightened us not only in terms of the kinds of questions that we ask, but how we collect the data. They're very excited about us using iPads. 20 years ago, we would not have used iPads to do our data collection. Paper records are a hassle. But it also helps us with information and trying to integrate data. The technologies that we have to secure data, as well as to transmit data, are so much more efficient than they were 20 years ago. We have lots of opportunities to take advantage of not only the database resources, but the virtualization of technology that allows us to better secure data and to keep information private that should be private, but also so that it can be an asset in research. And that's probably a little bit long of an introduction, but it kind of gives you a sense of the kind of research and the kind of resources that I use in research and that I'm very excited about. So thanks for being here today.
Thank you. Jamie, take it.
Good morning, everybody. The many lives and hats that I've worn are way too much to go into this morning. Just safe to say I started as a microbiologist, then I started dabbling with virology in one of the hospitals in the Connecticut area. I decided to join the Air Force, where I was also a laboratory director. Did a little bit of research in the laboratory. We were one of the first. We were the first site to come up with an HIV testing methodology, and that was because I was overseas on a base that was not covered by the FDA. So interestingly enough, we were treating military active duty as well as their families way back during the early 90s, I believe. Yeah, no, it was 1987. From then, I made the leap from virology or bacteriology to computers. And if you think it's not really that much of a leap, because if you think, what does a lab produce? Well, it produces two things, either a blood bag or data. So data's been around for us lab types for a long time. We've been using it tied to chemistry analyzers, and so it was an easy segue to make. And later on, I retired in theory. I'm working harder than ever. But I've been at Rush University Medical Center for 6 years. It's one of the greatest places I've ever worked at, and I've worked at a lot of places. One thing I like about Rush is the colleges, the research component, and the medical center operations all work as one. So if you go to a lot of other academic environments, you have a vertical for medical center, you have a vertical for research, you have a vertical for the colleges, and lots of times it's really tough to get those to meet on a single point. We do very well with the teacher-practitioner model. Our students go across the street, they learn their craft, and then they come back and then they actually practice it. So we're very proud of the bench to bedside, as we call it. In terms of public health and preventive medicine, hospitals are really struggling right now. And it doesn't take somebody to be in this business to realize that. All it takes is really looking at the Chicago Tribune, and you see mergers, you see takeovers, you see clinical integration products, and it's really quite a dynamic time for all medical centers, for all hospitals, big, small, urban, rural. we're all trying to get our arms around this because it's a tremendous paradigm shift for us. For years, for decades, forever, hospitals have been paid based on volume. The game has changed. Now you're going to be reimbursed for quality and for physician performance. And this is a very difficult concept, especially for the older physician population to grasp, simply because it's the way they've been doing this. Medicine is traditionally very hesitant to change, and even the electronic medical records has a lot of head spinning. We do have Epic as our EMR. It's one of the more favorable EMRs. I believe all the academic medical centers in Chicagoland have EMRs, and one would think because you all have the same EMR, exchanging data would be different, would be difficult, and it would be easy rather, and it is quite difficult. You could be on the same system and have a totally different structure, totally different business analytic tools, and it would be like you're trying to interface with another foreign being, if you will. So the hospitals struggle as they work this. Now, if you think about it, the federal government's kind of got this figured out. They love the carrot and the stick. So you've probably heard the terms meaningful use 1, meaningful use 2, meaningful use 3. That means that the institutions, both the ambulatory and private and inpatient, are being reimbursed by the federal government for achieving certain quality metrics. And you have a meaningful use 1, which was able to connect point A to point B. Like I said, that's not really easy. You think it's easy, but it's not. Meaningful use 2 basically said, okay, you're connected, now you've got to start sending data. Ooh, that's a little bit harder. First of all, it's hard to find a partner. Second of all, well, I don't really want to share my information with you. I don't know where it's going. And third, the ginormous security implications, famous celebrities getting their pictures in the cloud, etc., really resonates with physicians, board members. Is the security safe? And we all know just from even consumers, it's not as safe as possibly it could be. We have a Guardian program, which is run by Dr. Dina Romero in our emergency department. Disease surveillance program, which has been a grant from DoD, still in beta, but is a very powerful tool, and we hopefully will use that further to disease surveillance. And we're also very excited about the Capricorn project, and equally excited, I think more excited, that Dr. Balahota, who's no stranger to the IMD, he is now heading that project up for Rush. Bala's a great guy. He's very innovative and he's very visionary, and so we hope to use that to its max as well. One final comment I would like to make is that right now, as consumers, you are in charge of IT. I've lost that battle a long time ago. Used to be if you wanted to come to the medical center, you had to have a BlackBerry, and you had to register with IS. Now anybody can come in really and get their mail, and it's because consumers are demanding it. Consumerism is really driving technology in healthcare and in other organizations. What other technology or what other business vertical do you know of that would have people stand in line for 2 days in front of a store to buy the latest product that really doesn't do much for them? That's the culture that we have right now. People will sell their seats in the Apple line. That's the buzz with consumerism. It's an addiction. Many of us are addicted. I give kudos to the crowd here. Very few of you are looking down at your devices. But again, for those of us that are in it, just look at your sons, daughters, grandchildren standing in line at the restaurant, 3 years old, little iPad. This is only going to continue. The consumerization of healthcare is only going to continue. You see Apple now working with Cleveland Clinic. You are in charge of your healthcare. And if you don't feel it now, you soon will be. And that will force the medical community to change its workflows in order to meet the demands that not only the baby boomers, but those that follow them will also be demanding more and more of technology, including healthcare, as we go forward.
Thank you. Thanks to all the panelists for those introductory remarks. Bill, you talked a bit about the electronic medical records and the exchange and transfer of that data between healthcare entities and public health agencies. I think you've also had some experience with the CDC in that regard. So Kind of set the stage for us. I mean, how long has this effort been underway? How is it working out? Who all's involved? And where would you say it's at in its stage of progression or continuum? Have we solved the problem? Are we just really getting to the scratching the surface of the need going forward?
Yeah. So fortunately for those of you in the audience and those of us who work in the field, we're nowhere near solving the problem, so there's plenty of work to be done in the next few decades. But really the odyssey started for me around 2000, and it was before meaningful use. When we started to build the data warehouse for the Cook County Health System, we realized we shouldn't be, we had, the way that reportable diseases were sent to the health department was that a microbiologist would go through all the paper reports, would pull those out and put them in a stack for the infection preventionist to look through. The infection preventionist would handwrite a form, would fax the form, and then there would be fax communication or phone communications. And it was all coming together in a data warehouse, and we said, why don't we just try to do this electronically? So we built the rules around identifying those disease processes, and the first step was giving a line list to the infection preventionist and saying, here are the patients that meet these criteria. And then they were still handwriting a form and faxing it to the health department. So we tried to get grants to build that system, and eventually we did get enough funding to build by the communication directly to the Chicago Department of Public Health. So the way, since Cook County's within Chicago, the first step is Chicago Department of Public Health. And then it went from Chicago to Illinois in a handwritten form. So it's still, you know, it's been a very long process. The next step is eventually we set up the interface, and we're sending data directly to the Chicago Department of Public Health. And they said, why don't we do this for the whole city? And that was a process where you kind of beg people, would you be willing to let us put our software system, and we'll buy the server, you have the software, are you willing to do this? And it still was a big hurdle to get places interested. With the meaningful use, it was under the American Recovery and Reinvestment Act. Meaningful use became an incentive program under CMS, and once that was pushed forward, we were in the right place, and then healthcare institutions wanted to send their data. So we have our software certified, and that was a big step. We're certified so that healthcare institutions can check their box on the meaningful use criteria. And we're certified for the public health activities, which is immunization reporting, electronic laboratory reporting, and syndromic surveillance. And one of the big steps that Illinois took over the last year is that now eligible providers, so all physicians, can send data through the syndromic surveillance system as one of the public health criteria. So this is rare. It's one of the only states to have done this, and it's going to be a lot of work, but we'll see. Hopefully that has the opportunity to bring in a lot of data across institutions and improve population health. So,
Thank you. Thank you. Denise, you talked a bit about chronic diseases and the impact that the chronic diseases have on the increasing healthcare costs, and clearly there's a growing need to continue to manage the chronic diseases along with those costs, and that's a top priority. So what are some of the ways in which you're using informatic approaches to improve the quality of care for the many individuals that suffer from these chronic diseases?
Well, there's lots of technologies available now, and many are relying a lot on the electronic medical records, claims data, but also we still really do rely a lot on self-reported patient-reported outcomes. Those are critical to give context to any kind of health services utilization measure or any kind of economic measure. A couple tools that have been very helpful in this regard. I know some of my colleagues are looking at issues around medication adherence and trying to help with both behavior modification as well as looking at outcomes related to patient self-report, economic measures, value, health services use. But if you don't find ways to help patients who have difficulty with some of the complex medication regimes remember when to take their medications, all of those big outcomes that you want to study are sort of for naught. So even we talked a little bit about some of the mobile devices that are now available, and they're available in a whole range of communities. Rich and poor have mobile phones or some sort of mobile device. So it becomes a means for communicating with people. Simple text reminders are being used in research to help with reminding about medication, motivation kinds of statements, helping with weight loss management, any kind of behavior modification programs. Some of these devices are now being incorporated into research projects to determine whether those kinds of communication tools might help with some of the behavior modification. In terms of looking at chronic disease management, the revelations that are happening with electronic medical records, and despite a lot of the different types of systems that are available, and you'll hear more about the Capricorn Project later, but trying to work together with different institutions in not only healthcare but in research contexts to try and find ways so that our different electronic medical record systems can be used to study population health, to study chronic diseases where patients may be treated across institutions, not only outpatient care, emergency care, and inpatient care, but in the community environment, in the public health system, as well as in long-term care facilities, assisted living. The technology that's available to look across the continuum of care is being used.
Thank you. Jamie, one of the things that we didn't mention in your background is the fact that you're a veteran, and we applaud the work that you and Rush University have done in helping local returning veterans and their families, including a program where health information technology takes center stage. Could you briefly describe the work that's being done in that area, and particularly how the use of technology is playing a role in improving the health and well-being of the veteran population?
Sure. We have two programs at Rush. One is called the Road Home Program, and it is a clinic that's designed to treat patients with TBI, traumatic brain injury, or PTSD, post-traumatic stress disorder. It's headed up by, well, in my field, we call them rock stars. These are top physicians that come and they bring an entourage of PhDs and PAs and other scientists. Dr. Mark Pollack is our rock star in this case. He's the chief of psychiatry at Rush. And he has built a very impressive clinic with both public and private funding. And it's called the Road Home Program. And the design of the program is supposed to be not to compete with the VA or not to compete with other entities, but to provide additional service, perhaps, not only to the veteran but also their family. So if you're a struggling veteran with PTSD or TBI, or even you don't have those things, it's a very confusing landscape when you come back from military service. There's a reason why 22 veterans are committing suicide every month. And it's because there's a great deal of confusion, there's a great deal of trauma even coming back. I've had many military veterans tell me that the transfer from the United States to Afghanistan, it was a lot easier than coming back from Afghanistan to home. And a lot of it is just based upon advanced technology. Many of the military men and women who would have died in other wars, bled to death on the field, if you will, are now being quickly triaged. They go to a hospital in Germany, and they're being saved. Yet we're creating a fairly large generation of those coming back with one or two missing limbs, traumatic brain injury, and these men and women are very young. They're 20, 21, 22. The other part is that these types of things not only affect the military veteran, but they affect their families as well, both local families and extended families. So when the GI comes back and the spouse, either male or female, tries to deal with them, it's very traumatic because they feel it too, and they become part of whatever is going on with the veteran. So this clinic is designed to assist veterans and their families, again, not to compete with the VA, but to provide more perhaps individual service focusing on TBI and PTSD. not only for the military members, but also providing the social services for the families of which the VA cannot treat. In addition to that, we have what's called the Enabled Vet Program, and that is kind of ancillary to the Road Home program, but it came about because of Dr. Pollack approaching me about getting involved perhaps with philanthropy, and I said, well, you know, I can go to these Fortune 500 companies and ask them for help, but I said, what about, what happens after you treat the veteran? And he said, well, what do you mean? And I said, well, you know, having been military myself, I can't tell you how many young women I saw at Walter Reed Army Medical Center, which was my last post, sitting in a wheelchair, smoking a cigarette, listening to their iPod, one or two limbs missing, and they have no idea what's going to happen to them for the rest of perhaps a 60-year normal lifespan. So knowing that the whole family gets involved with this, I said, why don't we train these veterans for healthcare jobs, healthcare IT career jobs? And so I started kind of a, I guess, an idea turned into a movement, turned into a program, where we now have a 13-week program. We train veterans for healthcare IT careers. We don't really offer them jobs at Rush, because that would be simple staff augmentation. What we did was we took advantage of the recession, if you will, because no matter what the recession gave to us, healthcare still remained hot. IT still remained hot. And you put them together, and they're a really hot industry, not only in Chicagoland, but also beyond. So we started training military veterans, some with PTSD and some without, for these healthcare IT careers. And we offer, the thing that we offer that others don't offer is specific on-the-job training. So we do give some classroom type training, some online training, but the magic is with the on-the-job training, where they actually shadow an Epic person or a security person or a data person. Because even though veterans are being given generous benefits to get certifications and college degrees, when they go to a job recruiter, they're still getting, I'm sorry, you don't have any experience. So we offer that experience to them. And it's been quite effective. It's still a labor of love and small scale, but we're hoping to get other perhaps IMD hospitals involved, because the overall goal for this is to transplant this program not just here, but other places across the country, because this is a model that can be reworked anywhere in the country. And I could talk about this forever, obviously, but I'll give you one final example. We're in the middle of a virtual desktop infrastructure upgrade, which basically says we take your PC and we give you like a lighter box, because it doesn't make sense to have a PC with everybody walking around with tablets and iPads. So we're swapping those out, and that saves us about $600 per unit. Well, you multiply that times 8,000 units, and you've got a $4.8 million savings. And the veterans are part of that effort. They're actually being trained to do that, quote, VDI swap out. And to give you an example how marketable that is, we had one guy, Ken, he was a former Marine. He had his resume on 20 different sites. And of course, his reaction was, you know, none of them are calling me back, Jamie. And I'm like, yeah, that's kind of how it goes, Ken. But we put the Rush experience of working with VDI, shadowing, he's working with antivirus technologies. He put that on his resume at monster.com. Within 2 weeks, he had 3 phone calls and 9 emails back asking for, you know, hey, the second kind of round here. And so it's working. And so what we want to do is keep expanding on that model and keep growing it. And who knows, this could turn out to be a good study as well, I think, in terms of getting some data on the military transitioning veteran and perhaps their family members. The other part, too, is Dr. Pollack says, well, you know, Jamie, some of these folks with TBI, they're really bad off. You know, you could show them how a PC works one day, and the next day, they've forgotten everything. So I said, well, yeah, you're right. But what about the spouse? And he goes, what do you mean? I said, well, the GI can't work, we'll have the spouse work. Or how about my favorite guy, little Johnny, who's flipping burgers downtown but is a whiz with a smartphone. I could hook him up with Erica, who does medical apps. You don't think Johnny, even though he's 18, would be sought out for in the marketplace? And that's another thing that the VAs can't do. They can't train the military veterans. And so Dr. Pollack said, you'd really do that? And I'm like, yeah, why wouldn't they? And he says, well, gee, that's very interesting, Jamie, because statistics show that 29.1% of military families that don't have to worry about money, their improvement is like exponential. And I'm like, okay, so there you go. So I know that's kind of a bit of a snapshot of what we're doing with veterans, not only for treatment of them, but also vocational opportunities as well.
Great. Thank you. We got started a few minutes late, so we are going to go a little bit past the 9:30 hour. So, you know, we've learned about, and we intuitively know that there are huge, vast amounts of valuable healthcare information that's collected every single day during just routine patient visits. Some 50,000 just here on a daily basis in the Illinois Medical District. But, you know, we know there are opportunities for research through the aggregation, analyzation of that data that's being missed simply because the networks that hold that information can't communicate or collaborate with each other. There is a Chicago region-wide effort to address that very issue that I would like each of the panelists to address. It's been referenced a time or two, funded through an entity that was created by the Patient Protection and Affordable Care Act, known as the Patient-Centered Outcome Research Institute, and the Chicago entity known as the Chicago Capricorn, which is the Chicago Area Patient-Centered Outcome Research Network. So if each of you just take a couple minutes to talk about your organization, your institution's involvement in Capricorn, and really sort of address what you see as some of the goals coming out of that collaborative effort. Bill?
So just I'll give a little quick background. PCORI, the Patient-Centered Outcomes Research Institute, was mentioned. It was founded under the Patient Protection and Affordable Care Act, so it's a non-governmental entity that has billions of dollars through, I think, 2016 and 2019. Sorry, and PCORI wanted to build a distributed research network, and so they had competitive proposals evaluated for each to form little networks around the country that eventually then could be joined together at a national level. And so we're part of all the academic centers in the Chicago region are part of this network. And the idea is that we build a common data model. We then map our terms, the way that information comes out of the systems, to common terminologies and vocabularies. And then with one query that sits above all the institutions, they can quickly pull numbers from all of the sites. And that gives us many opportunities to study rare conditions, which you couldn't do on single institutions or even in one region. It also allows for the comparative effectiveness research that Warren mentioned earlier, where you can see differences in way patients are treated and outcomes based on those different treatment patterns. So I'll stop there. It's been exciting. It's been a lot of hard work, but fun, and it couldn't have happened, actually. I'll give a plug for the Illinois Medical District, but they've been a great neutral convener to get all these academic centers talking together and able to put together a proposal. And things have gotten better over the last 6 months or so.
The Capricorn project I find really exciting too. I'm in my role at the University of Illinois in the Clinical Translation Science Award program. I also have managed a clinical research data warehouse for the last 5 years, developed it, and that has become an important asset to this project because the data warehouse houses the electronic medical record for UI Health System. But what is really exciting about Capricorn as a native Chicagoan is to be able to work with all of these fantastic institutions in a collaborative way. That's not to say that we don't compete in other areas, but working with both VAs in the city, all the major academic institutions, some of the public health units, It's been very rewarding and also challenging because we all have different institutions. We're all trying to build a common data research network with, potentially serving up the answers to research questions that we all have, and we all have different ways that we want to ask those questions. So we're only right now 6 months into it in our first phase. This first phase is 18 months, and that we are hoping that we've made enough progress so far that we'll be competitive for phase 2, and that's when the work really begins. But hopefully the rewards will also come to pass. But also exciting about it is the involvement of the population, patients, communities, because they are there, us, as consumers, participating in the design of the project, the design of the common data model, in there talking about technology and what kind of outcomes we should be looking at. So it's very integrated, and that also makes it very rewarding.
Jamie?
I'm very excited about Capricorn. I've only been in Chicago about 6 years now, and I was working with our previous CMIO, Dr. Julio Silva, kind of as his wingman on the project. But I can tell you the potential for that is just ginormous. And it's not only for the benefit of the medical centers and the research centers. It's really for the patients. I think with this type of technology, we have the opportunity to reach out to those that perhaps are suffering in silence or do not get their immunizations or do not get even the simple flu shot. I think this is a very powerful tool that the sky's the limit. And it's really exciting to see the hospitals working in different ways and starting to ease up on that tight grip that they have on their data. I still have researchers that rather than put all their data in a nice backed up, cool, stored computer room, they rather keep it under their desk running Windows 98, backing it up themselves maybe, and then coming to me in tears when their hard drive crashes and we've got to try to fix it. So it's a great cultural shift. It's a tremendous cultural shift, which I think is even more enormous than the technology component. The technology is there. We've got big data. I was privy to go down to the University of Illinois down south, and they are just doing phenomenal things with big data. And I mean really, really powerful processors and data stores in the petabytes and zettabytes and Zulu bytes. They are actually doing things like taking handwritten census information from the 1920s and 30s, which used to be somebody came by your house and you wrote stuff down. Today it's yellow in paper, and it's very hard to not only decipher but to collect. They actually have technology that can read those types of obscure things. That's the power of technology, and it's good to see that us as humans are starting to realize that and use it for the benefit of disease prevention.
Thank you. There's a one-page document on each of your chairs that describes Capricorn in summary, and then on the reverse, a couple of other sort of medical science programming initiatives that are underway here at the district. We have just a few minutes left, so we do want to open it up to the audience for questions. Yes, sir.
Hi.
Please state your name and your
My name is
question.
Adnan, UIC student as well as a MD. We hear a lot about meaningful use too, and we hear so much about data transfer. You guys are doing some great research, but I still see a problem with these silos. A company like Epic, who's notorious for not wanting to share data with other companies, and they've done it through within their own system. They say, yeah, we can share data, we're meaningful to use, certified, but they're only sharing it within their own system. So how do you take the research that you're doing, Dr. Trick, and the research that you're doing, and let it go to Rush? And how do you let the information from Rush now go to Adventist Health System in the suburbs, or anywhere for that matter? There's so much awesome research, but where do we sit with letting it really integrate? I mean, I know that that's the future, but how do we get there?
I can try. One of the things that I mentioned is with some of the virtualization tools that are available, it actually allows data to stay where they are and still be able to use it. There's information exchanges where providers in one location can actually see the medical records in another, but the data reside where it originates. There's definitely some challenges we have with the concept of sharing private information, but the technologies that we are now starting to see, for those of you who are into statistics, we can actually now do statistics, regression analysis, that allows you to conduct that with the data residing where it is at multiple locations. Virtualized statistical analysis. You don't have to have a big data set under your desk or on a big server, a physical data set to actually do that. It can be virtualized. And I mean, that solves some of the, may eventually solve some of the research challenges, but as a clinician, the ability to integrate that data is still, we have not achieved that yet. Another aspect that I think might address some of that is you're starting to see in the VA we have something called My Healthy Vet, the electronic health records that are geared towards the consumer, where still that is institution specific. In the VA, it's actually cutting across the VAs, but I think if we start to see a consumer demand for wanting your own health record, regardless of where you go, that could become a consumer product. So there kind of has to be a business model that calls for sharing the data. What's the incentive for any one healthcare institution, as Jamie described, that's trying to survive in this competitive healthcare world, to share data with another institution? There has to be a mutual benefit to either accomplish quality and also show some business value too.
But you're absolutely right about Epic. They view themselves as a software company, not a solutions company. So if we have a problem and Loyola solved it, they won't share that Loyola solved the problem. Mm-hmm. And they're not alone. I mean, I pick on them all the time, but Judy Faulkner is a bazillionaire, and I work here. So she must be doing something right. But the game is changing, and so to really answer your question, what you do is you push Epic into the background. So that's just another system in your data center, mm-hmm. just like your imaging system, just like your pharmacy system. And oh, by the way, Epic does not do laboratory very well. It's awful. And it's because they don't want to deal with the FDA. So there is no module, blood bank module in Epic, so that forces the customer to find some other solution, mostly Cerner. But truly the answer is you push all of these things in the back and you let the processors and the powerful tools just extract that data, and you make it so it doesn't matter where the data is coming from. So it gets past all the company kind of politics where we don't share or we don't do this or do that, and you just make it another system back in your data center where you pull the data and you put it in separate systems where you can analyze it, massage it, cleanse it or whatever, and that's the system that you use. And that's what I think is going to happen, not only to Epic, but to Cerner, McKesson, Allscripts, because they're going to be legacy systems, and I think they're going to be legacy systems sooner rather than later.
Mm-hmm.
Thank you. I'm going to defy my staff who's telling me it's time to stop, but I'll give you an opportunity for one more public question. Yes, Brenda.
Hi, I'm Brenda Bushmelling from VOA, and I was really interested in the behavioral modifications or the medicine tracking toward reduced readmissions that you spoke about, Doctor, and was interested in any retail partnerships, because that seems to be with Population Health some of our future. Mm-hmm. And have they come to you with ideas about information sharing and wanting to partner in this endeavor?
I can't speak to any of that, but I could imagine some opportunities, especially with medication adherence. But I'm not personally working with any retailers right now. I know others have.
Bill, any comments on that?
No, I think that's something that Denise has worked closely with. We haven't, we've talked a lot about it, but we haven't done much in terms of mobile technologies. And there are a lot of data sources that you talk about integration. We can integrate our health systems data, but we also have, like I said, pharmacies and those transactions, which are huge databases, difficult to share, difficult to set up the technology. and there has to be a good business case for them to want to share their data.
I would say watch out for Walgreens. They got a lot of clout, and it seems like they're building all over the place. I mean, I've got like 3 Walgreens within a 2.5-mile radius. And, you know, they've already kind of figured out, hey, let's not sell tobacco products. Gee, that seems to have worked. And minute clinics, get your flu shot, maybe have a nurse practitioner, and then they'll have that data from the patient. I think they're going to be a major market player in healthcare going forward, simply because of the convenience for the patient. You already get your pharmacy prescriptions there. And I see them hungry to go after that as well. I may be a contrarian, but
No
see what
Walgreens
happens.
in the medical district yet, but stay tuned. Dr. Mulshine.
Jay, I just want to point out, CVS got rid of the tobacco products. Walgreens, we're waiting for that.
Okay.
Thank you.
All right.
All right. Well, thank you very much. Let's give our panelists a round of applause.